right, well, why don't we go ahead and get started as folks continue to log on. First of all, I want to thank everyone for taking out the opportunity to join us this morning. In particular, I want to first do an acknowledgement to our virtual network, in particular, the patient partner innovation community that Desiree Bradley so proudly organizes on a regular basis. And it's a virtual network of patients that really follow our work in quality improvement. Of course, want to acknowledge all of the folks that are working, the essential workers, the folks that are working on the front line in our hospitals and our health systems delivering care during this pandemic. Certainly, we want to make certain that you understand that we send you our heartfelt thanks for everything that you do every day. We want to celebrate the work of, in particular, my governor, our governor here in the state of Illinois, and the mayor of the city of Chicago, Mayor Lightfoot, for just a tremendous job in their leadership over, this past couple of months. It's certainly been a very intriguing time for all of us. And so, just to acknowledge the work that they're doing. We also want to acknowledge others. So folks that are in the policy space. In particular, I want to honor and acknowledge the office of Senator Mike Casey, who is present this morning. I also want to acknowledge the office of our state senator, Debbie Myers-Martin. Thank you so much for your contribution and all that you do here for the state of Illinois and abroad. Really, let me give you a little bit of context about why I felt it was important to really have this conversation and to call on my colleagues to really begin to share some insight. COVID-19, obviously, for those of us who are in the healthcare space, and in particular, those of us who work in the space of focusing on health equity, the impact of COVID-19 from a national perspective in terms of health disparities, I don't think that that's very new. I think that what is new is that we have not seen, at least in modern times, where an outbreak in particular, something, in the healthcare space actually impacts our healthcare system, impacts our education system, impacts transportation, agriculture, housing, even the activities that we indulge in both culturally and socially. And so this pandemic it has really been an extremity for us. What it has caused is, it's really prompted a new conversation, whether it's Congress, whether it's state, our local government, all really working to mobilize to deal with this pandemic and the outbreak across this nation. So I don't want to focus a lot on the numbers because, again, I think the news has really done a great job of, bringing or heightening the awareness around health disparities and the issues that we see, in particular with the African American community or the Black community. But what I found really interesting, and the reason why I, again, wanted to have this conversation and pull this group together, was the fact that the focus to date, when you hear a lot about solutions and things that we need to do, the focus that I've read and that I've seen, whether it's been me attending the NAACP town halls, or reading what's in the news, or reading or listening to CNN, the focus has been a lot around our public health concerns, which of course we know are very vital and important. So this is not to negate that at all. It has been around own behaviors as people and communities, right? More so around social determinants of health, right? A lot of conversation about, you know, where you live, the economics of things, you know, what we eat, and how all of these things contribute to our health outcomes. But the one thing that I haven't heard that I really wanted to shed some light on today is this focus around our health system, meaning our hospitals and our health systems and the roles that these organizations play in the elimination of health disparities. Now, me, and I think this is, you know, a great opportunity for us to talk about the work and acknowledge the work that has been going on nationally in this space, to shed some light on that work in hopes that as we come out of this COVID environment, as we come out of this pandemic, we actually take what we have learned in terms of what hospitals and health systems can do from the standpoint of promoting health equity and eliminating disparities, what they can do, and now focus on a more systematic approach, or use a systems thinking approach nationally on how we can drive better outcomes for all communities and for all patients. And so that's really what this conversation is about. Today's discussion is not to elaborate on the conditions of health and health outcomes for Black and Brown communities, but to talk about the roles of hospitals and health systems and how their role and what they can do in playing in eliminating these disparities. So I just want to be clear, you know, the issue of health disparities is multifaceted, right? I think we all know that, and therefore that requires a multi-pronged approach in our solutions. There is no one singular answer. But again, because I haven't heard, in the context of all the conversations that are going on, the roles of hospitals and health systems, I felt that it was important to begin to bring colleagues of mine that have been working in this space for a number of years and understand that it's not just about care delivery, because I think a lot of times when we think about hospitals and health systems, right, we think about them from the context of care delivery. And what I want to open your thought process to, it's not just about care delivery, but it's the how you deliver care. Mm-hmm. It's the how your health system functions as a means of eliminating health disparities. And that's today's discussion. So if there are two, things I'd really like to kind of bring out in the conversation today, it's, again, defining the role and level of accountability hospitals and health systems should have towards this issue of eliminating health disparities, and then also explore potential policy. So we're going to talk about this in the context of policy and advancing that forward. So policies that would support the development of perhaps a national equity goal. And I'm going to start with Dr. Wyatt, because I know that, you know, this is not a new topic for you. You have been a friend, a colleague, and a champion in this space, and have worked nationally to partner with hospitals and health systems in this quest to help them see the light about their role in eliminating health disparities. And let me say this is not just a community, you know, when we talk about eliminating health disparities, and the first thing, you know, everybody talks about is either public health or community health. Right? What we're doing in community and public health. And while those things, again, as I stated before, are very important and vital and key to this work, I do believe that we have to take a systems thinking approach to how we do this work, which means that there is a different level of accountability. There is a difference in the way in which our hospitals and health systems should perform that also contribute to the elimination of these disparities. I will also, let me acknowledge before I ask you, Dr. Wyatt, to jump in, that all phone lines are muted for the time being until our speakers have had an opportunity to talk. Once we open it up for questions and answers, you can raise your hand to ask a question using the system. And if you're on a phone line, you're not on video, you can press *9, and I will see it prompt up here, and I can open up your mic for you to ask your questions. I do also ask that you utilize the chat function within the platform. I like to have interactive conversations, so it's always nice to see folks sharing their thoughts as the speakers are speaking, so I encourage you to do that. Desiree, thank you so much. And we also are asking for those that are joining to please do not forget to share your name and your institution in the chat. This session is also being recorded, and it will be shared, in particular with our legislative partners as we continue this discussion. So with that being said, let me start with you, Dr. Wyatt. You know, we're seeing in popular media the outrage around disparities, African American deaths in particular with COVID-19. We've been working in the space for quite some time and know that disparities are not new, and in particular disparities within the African American community are not new. Can you give us some historical context, just to do some level setting with our participants on today? Context around health disparities, particular among persons of color, and what you commonly reference as the stuff that's killing us. Dr. Wyatt?
Yeah. You hear me okay, Dr. Washington?
I can.
Okay, so good morning, Dr. Washington. Thank you for putting this together, and I'm just honored to be a part of the team there. New friends of mine, I've worked with Kelly before, and I want to give a shout out to the good work that Vizian's done in this space over the years. Also, since I've been sitting here, I've been getting text messages from people just not only locally, but there's a small group of friends of mine who's dialed in from the UK that I work with on equity and disparity and some of the issues they're facing as well. So just a shout out to them, Noreen, Paveen, and Nalam, who dialed in. So as we began to think about what we're facing, to your point, Dr. Washington, there's nothing new here. As it relates to disparities. They're well documented. And a few years back, I had the opportunity to visit with a friend of mine down in New Orleans who wanted to talk about these things that were killing people in New Orleans and Louisiana, ironically. And he didn't say the stuff that's killing us. He used another phrase that sounds kind of like shiggity, that's killing us. And when we began to talk about that, they were the things that are on the screen before you there. It's the history of redlining, gentrification, what now in Chicago is called urban renewal. What it amounts to is just pervasive residential segregation. What it amounts to are weaknesses in the educational infrastructure that limits opportunities. What we're talking about here in communities of color is just fewer resources, fewer access to fresh food. When I hear federal officials say for Black and brown people, if you stop consuming so much alcohol or stop smoking, somehow you will be better off. Well, the fact of the matter is, from a policy perspective, if we start to say, why not target the companies that target Black and Hispanic communities and other non-white communities as it relates to alcohol and tobacco and junk food and all these things that we know are killing us. We know that poverty is one of the things that kills us in our communities of color. We don't have to go into the science on this. The science is 100% clear. We know that in terms of quality of care, from the simplest intervention to what's most complicated, Blacks and other minorities do receive poor care. These populations receive less intensive care than the white population. This is known, and not just in the US, this is known in Europe and the UK, and even from experiences I had in the Middle East. So along comes COVID-19 that almost makes it look as if we are somehow disposable. We are not disposable. So when we look at these factors that I put on the slide around what is killing us, Dr. Washington, we have to think about, even before we get to how, we start with who, and who are vulnerable populations, Black and brown populations that are now just at the tip of the spear on what COVID is doing across this country and in fact across the globe. What we see now in stark expressions is how the populations that are most at risk have been ignored, and somehow their invisibility has been normalized. And we have to start to think about then, underneath a pandemic, what is it that continues to drive this invisibility that makes it appear that Black and brown communities and people are somehow disposable, when these things that I put here are really the things that are killing people, which includes lower income, jobs that are underappreciated, but in the face of COVID, people who still show up and do their work every day because they are an essential part of the workforce. And now a lot of people began to realize how essential these underappreciated jobs have been and how invisible they've been until now we face with a pandemic. And as I talked with Don Irwin, who runs the St. Thomas Clinic in New Orleans about this years ago, we have to begin to think about what are those structural and institutional causes that lead to what we see, that leads to what is killing us. Those are those upstream things. And if we say, well, it's because Black people or brown people have diabetes, have high blood pressure, have obesity, have asthma, that is the end result of a system of care that has failed these populations, that have failed these communities, and where health systems, through policy implementation, have failed the populations that they are there to serve. So we have to move back upstream and say, what are the structural institutional factors? And we cannot get to eliminating this disparity without eliminating inequities, and we cannot get to eliminating inequities, frankly, unless we deal with structural and institutional discrimination, that we deal with structural and institutional biases, that we deal finally with structural and institutional racism that has contributed for far too long in killing us. And from a historical perspective, if we go back to the Civil Rights Act of 1964, it said you cannot discriminate in healthcare, along with other things. And for many, well, that was the thinking that was somehow going to eliminate disparities. It has not, because it has been ignored. If there is any policy that any healthcare system, healthcare delivery system should go back to as a framework, a guideline, as a call to action, go back and read the Civil Rights Act of 1964. And for those that may be on the phone from Georgia or Atlanta, when that happened, many hospitals like Grady constructed a wall to divide Black people from white people. And that's why in Atlanta, some people will call Grady the Grady's, because if you look from above, it looks like an H. Mm-hmm. And those were the two Grady's. One was a Black Grady, one was a white Grady. So these are the things that's killing us, and I'll pause there.
Yeah, so Dr. White, I wanna bring Dr. Agarwal into this, because we've done a lot of work together, both from a research standpoint, also in the community. One thing that has always intrigued me working nationally has been, when I talk to hospital administrators, oftentimes what they will say, and I won't use the word excuse, but let me call it for what I'll call it for what it is. Oftentimes there's been this, but we treat everyone the same, right?
Right.
We don't discriminate, right? We treat everyone the same, meaning that we have this standardized approach in medicine, and obviously you're a medical doctor, we have come a long way, right? When we focus on quality improvement on standardized care plans, right? So if you present with pneumonia, there's no difference between, pneumonia with Natasha, Ron, so on and so forth. But what we're suggesting is that at times there are different levels of resources that need to be applied depending upon the person, right? And we know that in some systems, and we know that in many cases, and we've seen this both nationally, that at the end of the day, the truth of the matter is that if you are a Black or brown person, that care can be different. If you are a Black or brown person, that the results or your outcomes can be, to the extreme. Dr. Agarwal, can you kind of bring some context to?
Sure. I think, the first thing when you said we treat everybody the same, that's part of the problem. What does that mean? To say that we're going to deliver care, do you understand the context of the person receiving those recommendations? Where are they coming from? What are their resources? And that's what we do not pay attention to. And this is what continually gets us into trouble. And it's an issue that we deal with every day. We're seeing it right now. We're seeing it with our older adults right now, what's happening. I always say this is playing out in the field. And the field to me is the community. And this is exactly what's happening. So I think to a couple things from Dr. Wyatt, his comment about the structural biases, the structural discrimination, and the racism, this is very, very important to call it out and to talk about what this is. There are structures in place where we will say, well, we do this with everyone the same way. Well, already that means you don't understand the sex differences that may be occurring in what you're asking people to maybe go through from a medical procedure, and or you are not understanding the race ethnicity issues that people face when they go home. And I think one of the things that I'd like to bring up in this discussion is that coming to the system is just one part of the whole care, if you will. It's in the field and in the community where the emphasis should be, so that when we have issues come up, the system can understand why it's being overridden. The system can understand, whoa, well, wait a second, what's happening here? What's happening here, it's been playing out forever in the community and it has not been addressed properly.
Yeah, absolutely. Dr. West, your thoughts?
Yeah, just quick, and have been having conversations with providers, and so something that really stands out is this, is that providers are very frustrated because they've said that for years we've had some proposals in place to address before COVID, something as simple as a flu pandemic or the annual pressure that the respiratory season places on the healthcare system. Within those, requirements for additional, we say, respirators or ventilators. However, the economic decisions that get made as a result of that is that, well, the populations that are most at risk, or that add populations that are predisposed to having respiratory failure, whether it's asthma, COPD, or add a disproportionate burden on the system, and an immediate return on investment, right? So, because of the payment system that goes with that population. So if you're talking about a population that has, a lower reimbursement, where now we will have, 22 million people file for unemployment within the past 4 weeks. So now Medicaid in and of itself, and the uninsured, and the number of people who are coming in who are uninsured, who don't, still, despite the ACA, despite any other requirements, and they're showing up, and there's decisions that are made early on in terms of to treat or to not treat, and they're the same kind of practices that occur even COVID, right? And so, but now what it is really, what the COVID-19 situation has really elevated are the underlying structures that lend to that kind of imbalance.
Yeah, I think those are such very important context with regards to our health delivery system and what we can do differently. That was the backdrop to the work, right? Let's talk about what we have been doing, because and I'll use myself as an example. In 2010, CMS invited me to come and begin partnering with them as our nation was looking at improving the quality of our outcomes, right? So to Dr. Wyatt's point, you got, what was it, 1967, correct me if I'm wrong, Dr. Wyatt, I don't have my notes in front of me, it was the Kerner Report, right? And then in 1999, we had To Err is Human, right? Which really demonstrated the catastrophic issues that we had within our healthcare system. And it really outlined 6 domains, I'll call them, right? Which the Institute said, these are the things that we need to focus on in order to improve our health system. And not to name all of them, but we've focused on every single one of them with exception of equity. We focused on patient-centeredness, we focused on timeliness, we focused on all of these other aspects of what we know produces quality, but that equity piece we have not focused on. So in 2010, when CMS, said, come and partner with us, one of the first things, and I'm so grateful to that the then leadership nationally, where when I asked the question, well, how are you going to focus on a national quality improvement program? It's a large scale project, but you don't have a focus on equity. You don't have a focus on vulnerable populations in this. And I'm looking at the objectives the way they were outlined at the time. We're going to reduce hospital harms or hospital-acquired conditions by 20% over the next 5 years. And my question was, great, I love it. But how are we not going to do that in the context of looking at vulnerable populations and looking at health equity as a means of getting there? And I'm grateful to that team because they took my question and they basically converted it into an initiative. It became a part of the work that we did. So over the course of the most recent 10 years, that's 10 years worth of work, these organizations, CMS mandated that each of the participating 3,600 hospitals across the country, as a part of that quality improvement initiative, had to include health equity. So they had to have an objective around equity. So this work can be done on a large scale basis. And I want to, talk a little bit about Kelly in particular, the work that Vizient has done. What are some of the strategies that you've seen hospitals and health systems to address this issue of health disparities?
Yeah, thanks, Natasha. We at Vizient are part of CMS's community of hospitals that's working on what Natasha just pointed out, the goals of the Partnership for Patients, it was called. We've gone through some iterations, but Vizient's working with 275 hospitals under this program with CMS.
Kelly, let me jump in because I don't know if but your mic is not as clear as when we did the mic check. Is there some repositioning you can do so folks can hear you a little bit clearer?
Let me try that. Is that better?
Not much, but just for the sake of time.
I'm not sure what happened.
Okay, all right. It could be the connection. Okay, finish. I'm sorry.
Okay, that's okay. We've really worked with our hospitals to try and bring out the highlights of what some of them are doing to address the health disparities that they've discovered in their, within their hospital. And two, I want to point out, one is Bovant Health. That's a large health system in North Carolina, and they've really worked on looking at some clinical quality measures and stratifying those by race, ethnicity, and language. And they discovered that African American patients within their health system had higher rates of readmissions for pneumonia. And they really dug into that and learned, there was a lot of issues just around their practices and their standard policies. We're talking about treating everyone the same when in fact, that concept, although, on the surface seems true, There's different ways that people receive things from the hospital. For example, they realized that their follow-up calls to the patients after discharge were not being answered by their African American patients, because the phone number was coming from the hospital and the patients assumed that was a bill collector, calling about the bill, versus the nurse checking up on them. So they reprogrammed that process and worked with the patients while they're in the hospital to program the number in to say that it's the nurse calling from Novant, not the billing office. And their calls got answered more often. They did just small things, small changes like that, many small changes though, and they were able to not only eliminate the disparity in that outcome, but they reduced pneumonia readmissions for all of their patients. And we know this work really, when you target the population that is most at need, you decrease the outcome or improve the outcome for all of your patients. So, we've really at Vizient tried to frame this work in that way, that this is a quality improvement tool for you to use to find and target your patients that are at most need, and really examine your processes and how they affect those patients. And when you shore that up, you improve your outcomes for everyone.
Yeah, so one of the things, it wasn't just about the collection of race, ethnicity, and language data, but that was a start, right? Because
Right.
you got to know what you're talking about or the who you're talking about in order to begin to understand what are some of the changes or strategies that need to be made in order to improve outcomes. So the first thing obviously starts with the collection of the data, but then it's how you utilize the data. And so, one of the other things that really intrigued me with the COVID data that's been shared, you see a lot of, folks still reporting that other, right? I mean, a huge majority of, of those patients are still labeled as other, while we know that this has been something that hospitals have been working on over the last 10 years. And so you got to ask yourself the question, why? Why haven't we focused on improving the quality of collecting that data? And then if you don't have quality data, how can you now begin to really focus on improving outcomes, right? Because the purpose in having the data is to now say, okay, well, here, we have a problem with the African American population. Kelly, we've done this with readmissions, right? When we looked across all of Vizient's 200 something odd hospitals, we saw staggering disparities between African Americans and all other races being readmitted. So we started asking the hospitals, okay, so help us to understand what's going on here and why is this phenomenon, not just that we have readmissions, because that's what most hospitals get stuck on, is that, oh, we got an issue with readmissions, we're going to be penalized. No. Why are we not beginning to really understand our data in a way that's driving improvements in outcomes? Because now, when we found out it was the African American population, then we went back and we discovered that it was low literacy rates, as well as language being a barrier with the Latino population. And so then we could begin to address to some of the activities that Kelly's talking about that Novant has done. We could begin to address programmatically what are the needs of the population in order to improve overall outcomes. Let me bring
that. Yeah, Natasha, can I just add into
Absolutely.
this? I think this will set up Dr. Wyatt well. So part of the work that I also did with CMS was I helped co-lead a health equity affinity group that brought together all the organizations that were participating with CMS in this project. And we conducted a health equity organizational assessment in 2018, 2019. We had over 2,300 hospitals complete this health equity organizational assessment, and we asked about collecting race, ethnicity, language data and how you collected it and what you did with it. And it was, just staggering that over 80% of those 2,300 hospitals collected the data. But only about 24% provided annual training to their staff to on the best practices to collect that data, and only 21% had really a robust verification in place to verify that the data that they showed matched their community data and other external data sources that really showed them, okay, yes, we're collecting this properly. And then when you got into what they did with it, over 50%, surprisingly, 51%, actually stratified at least one measure by race, ethnicity, or language. But sadly, then we got down to only about 15% communicated that information, and of that 15%, it was internal. 5% of those really shared that externally with their community, and fully only 21% actually implemented systemic changes to reduce disparity that they found.
Yeah, I want to bring Dr. Agarwal in really quickly before you comment. Dr. Agarwal?
Yeah, I was just listening to Kelly, and Kelly, thank you so much for mapping that out for me, because all I keep thinking about activation. What did you do with that data? How did you use that? And what can you see from it? That is huge here in this discussion when you talk about systematic change and what Natasha keeps focusing on. We have got to look at not only did you collect, but what are you doing with that and closing those loops? And this, frankly, is very acutely felt in the community. My work has been in the community for over 20 years. I've done home visits on 2,500 homes here in Chicago, listening to people talk, and it's predominantly minority communities on the South Side, listening to what the issues are. And one thing that keeps coming back to me was, okay, we're collecting all this. What do we see for it? Why does it matter? How does it help us? And that goes back to what Dr. Wyatt is saying. Who's the who? Who are we trying to serve? And one of the things I want to bring up on this call is this. I have a classic example of a system that has been in place. Primary stroke centers here in the United States have been in place, where we have these specialized centers in hospitals around the country that are ready to handle acute stroke, okay? And they have people on board for 24 hours around the clock. Acute stroke comes in, they can be assessed quickly, they can get the team going, we can assess whether we can give TPA or not. All right, my work in the field consistently showed in the communities where we have high stroke mortality and morbidity in Chicago, few people, if any, knew that down the street, that hospital was a primary stroke center. And it was so shocking to me, and it disturbed me so much that I called my colleagues up at the academic center that I work at and said, what is going on? What is happening here? Because you have a system in place, yet people in the community don't even know about that system. And that started the work with Natasha and with my other colleague, Dr. Prabhakaran, who's at U of C. We need to get the messaging out about these systems in place, and we need to understand who are we serving. Simply putting a system in a community and nobody understands what it does, why it's important, how it's going to help, what they need, what the system needs, is crazy. And that is what we were doing. And we started this whole mini internship program. So when you talk about a program, we said this was the approach. We are going to bring people in the community, and we are going to go into the emergency department, and you are going to see how this team works to help people from your community coming in for stroke. And that was a guided tour led by myself, the other physician, and this is another important point, physician-led. This is, if the physician doesn't feel or doesn't want to be in these kinds of discussions, that means it's not important. And that is what people feel. Well, the doctor didn't say anything. The doctor is not promoting this. Therefore, it's not that important. So we felt very strongly with that, but we also felt very strongly having community guidance here and our trusted leaders in the community who people know and trust. So we took them on the tour. We walked through the ED. Strokes were coming in and they could see what was happening. I stood back, Dr. Prabhakaran stood back, and now organically the questions start to come. Why is that happening? Why didn't that happen? Why isn't my mother getting an MRI? Why is she getting a CT? You only get this kind of knowledge when you're in it, when you're in the field. And then after we did that, we then had the educational piece to our community members, which Natasha led with the team. And I think from this kind of experience, we are showing there is a system there, but now let's see how we can make you use the system. You understand what the system is about, and you can know what to expect when you activate that system. And we honestly, in the healthcare system right now, we do not do this. We don't take the time to do this. We don't take the time to educate about this, and we have to, because this is then getting bi-directional information from the community to us, and from us in the system back to the community. And it's a constant loop, but this is the only hope we have in really combating and really diminishing and eliminating these disparities. If we don't do this, nothing is going to change.
Yeah,
so I wanted to just bring that up, Natasha.
I appreciate that. And Dr. Agarwal, let me put something out there, because again, I really want us to focus on the solutions and pushing for policy
Right.
that really begins to move us in a different direction and towards improving outcomes. Two things. Number one, I think you've clearly heard that we can pull together a systems approach to a national equity goal, right? We've done it, integrated that into the work of quality improvement through the Partnership for Patients, and certainly establishing a national equity goal is something that we can absolutely do where there is a focus on eliminating disparities, number one. Number two, in order to further do some of the things that I've heard from my colleagues, in particular, I think about you, Dr. Agarwal, and Dr. Prabhakaran over at University of Chicago, is that leadership diversity and diversity on the board level is something that they knew was crucial. In other words, when she started asking the questions, she started to pull in people that looked like the community, people that were aware of the issues, and people that they could partner with in order to advance this programming. And I think one of the major issues that we have, and shout out to all of my colleagues and friends with the National Association of Health Service Executives, I think I saw Susan on the line, is that it is so critically important that we begin to look at the diversity of these teams that we're pulling together. I get calls all the time about folks asking me questions about, equity. Can you refer me to somebody who's had a story around this? Oh, I'm looking for an African American. And you know what I did? I actually stopped answering those questions unless the organization can demonstrate to me that they actually have diversity in their leadership. Like, don't call on me, to be your, and I'll just use the lack of word, pawn, in short, to answer your questions when I'm looking around the table about all the people that are making decisions, and the people that are making the decisions are not people that look like me and understand the issues and have life experiences like myself.
Right.
And you cannot tell me that there are not people that are qualified to do that work. So we know this can be done. So number one, a national equity goal. And number two, the promotion of more folks in leadership, in particular at the board level and in hospital leadership, that can work to promote this. Let me bring Dr. West back into the discussion. Dr. West, do you want to talk a little bit about, what you've heard and just some of these strategies, if you will?
Yeah, I just want to say that there are four guys in health equity, right? There's the identify the problem and prioritizing what reduces the health disparity. So one of the issues right now, for example, is the difference between actually screening for the disease versus the diagnosis of the disease. And then learning from that in terms of identifying what actually is the cause of death, of false positives. Is the implementation of the actual intervention. But then the last two I's are really critical: to invest and to incentivize. And I'll give you two really quick examples in that regard. Sinai Hospital in Chicago, there was a Chicago Tribune report and a report on the days of cash held by hospitals that were predominantly served, that were serving Chicago's poorest communities versus hospital like Mount Sinai have less than 7 days worth of cash on hand, and a hospital like Northwestern have over 400 days worth of cash on hand. that kind of gap in
Mhm.
of the available resources to invest in community-based programs are key drivers to what you're going to get out of that system. The second thing is the investment, right? So you place capital in terms of building up the infrastructure around the safety net itself to incentivize also providers into actually seeing the patients. So quickly, we're working now on a specialty care initiative where we have specialists, gaps in and waiting lists to see specialists for patients who are, either uninsured or have Medicaid, because the providers are saying there's no incentive for me to actually see those patients right now, given that ACO or accountable care entity structure or the reimbursement that I'm facing. So we have to think about those 4 I's of identifying, implementation, investment, and incentive, and how they really impact the population from a policy.
Mhm.
Can I jump to Dr. White? Can we go to policy? And can you talk a little bit about opportunities from a policy perspective, to really begin to systematically advance this work?
Yeah, so thanks for that, and thanks for everybody's contribution. I'll get to the policy as a start that I would recommend, but I think we really do have to recognize there's a system in play here. There's a system that uses a playbook that's been used for 300 years in this country. And the system is perfectly designed for COVID to kill Black and brown people. Mm-hmm. It is a system of structural and institutional racism that needs to be eliminated. And we can start with policies. There is no such thing as a safety net in Evanston. There's no such thing as a safety net in Buckhead in Atlanta, right? There's no such thing as a safety net in the high-income communities in Boston, in the Upper East Side of New York City, or in Richmond County and outside of San Francisco. We need to eliminate the term safety net. Mm-hmm. Saying safety net in and of itself devalues people that live in that community. So if we're going to achieve equity, we have to eliminate inequity. Mm-hmm. And to eliminate inequity, we're going to have to look at policies that deconstruct a system that is built on institutional and structural discrimination, bias, and racism. So when we begin to think about that, then, what is it that at this point, since COVID-19 has told us we have to do something, at this point, how do we keep COVID-19 from becoming COVID-20, COVID-21, right? How do we do that? And who do we do it for? So to your point, Dr. Washington, for years, and you know this, I have advocated for, I will continue to advocate for a national patient safety goal for health equity. And this was focused around some of the topics that have already come up. How do we begin to collect, aggregate, and stratify race, ethnicity, and language data, and to move that into elements of performance that holds health systems accountable for the processes and the outcomes when the data is right in front of you. Vision has a marvelous clinical database that I used at Cook County that said to me, across this country, a leading population of readmission of Black men with sickle cell crisis who go home with a pain level of 7. So if I leave there with a pain level of 7, guess what's going to happen? If I came in with a 9 or a 10, I leave with a 7, I'm going to be back there in 72 hours. If there's a stroke center, we market stroke centers certified, but if a young Black woman comes in who's 38 and someone decides through their implicit bias that this can't be a stroke, and she ends up permanently damaged because my bias said, no, this can't be a stroke, or this person is not valued enough. That through real strong policies. So a national patient safety goal, number 1, look at how we collect, aggregate, stratify, and implement activities that will decrease these poor outcomes. Second, look at how we manage language access and language services, right? When we come into a hospital, we shouldn't rely on a friend, a care team member, the Uber driver, or someone else to interpret for me. I shouldn't interpret for a family member when I come into an accredited organization or any organization. So if we began to think about having a national patient safety goal that now organizations who are accredited must comply with, and that CMS endorses, that means that it will extend beyond accredited organizations to all organizations. It means it will be picked up even internationally, because once an international organization says there's a national patient safety goal, here's a mechanism, here's a method, here's a process for us now to begin to address these things and to completely redesign systems that by any measure, has failed Black and brown people in this country. So we're to the point of having policies just like the Civil Rights Act of 1964 that says, now here are the things that you must do. It is a federal violation if you don't. And it's sad that we have to get to that point. And that's got to go to the C teams and the boards of directors, and they make it a strategic priority for the organization that we will achieve equity, that we will make it a priority, that we will look at every contract to make sure that our contracts are distributed to female-owned and minority-owned businesses, that we will make sure we have professional development program, to your point, Natasha, that's not just gonna make us more diverse, but it's gonna make us more inclusive. That there's professional development plans that says, if I start as a junior nurse, that I know that I have the opportunity to become a supervisor or a nurse manager or a nurse executive, that's in place and is a priority in that organization. Those are the kind of things we need to make sure that health systems prioritize and monitor and measure and hold themselves accountable for, and to recognize, to your point, Dr. Agarwal, that all health systems are there to serve the community. The community is not there to serve us. So being a part of the community, knowing what the community is saying, respecting the community, empathizing with the community, loving the community that we're there to serve. And it's unfortunate that we got to think about a policy that regulates how we love people. That's where we are, because people are dying.
Yeah.
So I say a national patient safety goal will be a major step forward. And I'll pause it.
Yeah, I totally agree.
Can I add just one
Yes.
small something that's happening real right now that hospitals and health systems are facing, because I'm part of a bioethics network where we've had to have conversations around the rationing plans that hospitals have started to consider, and networks that health systems have started to consider, and how do you eliminate bias in a rationing plan? And so, having, these hospitals and health systems facing years of the question, decades of the question of bias and discrimination, but or begin bioethics of a rationing plan, and then overlay that with, conversations and considerations for equity and disparities, are really, really bringing some underlying issues to the surface.
So I'll say to that just briefly, when was healthcare for Black people not rationed? Allocation of healthcare resources for Black and brown people has always been rationed. So now we want to talk about rational allocation. We started rationing healthcare for Black people in 1620, through 1700, through the 1800s, through the 1900s, when we rejected a universal health plan for the US because corporations did not want Black people in hospitals. So for Black people, brown people, poor people, and rural white people, resources have always been rationed to those populations, right? So we got to think about what this rationing means in another way. Rationing means give me what I need. And that means that I might have to take it from someone else to give it to people who need it. And we have to demonstrate that we value the people that need it. That's not rationing. That's meeting the needs of a population.
Right. And that's true. And that's finding the need and filling it. And that's it. Natasha, I want to just make a comment here because you mentioned this about diversity. You know, I sit as the Chief Diversity and Inclusion Officer for AMWA, the American Medical Women's Association. I'm obviously all about diversity, but it's really the inclusion. And I say this all the time. If you include, you will get diversity. It's a byproduct of that. Yeah. And the problem here that we're talking about, what Joe is talking about, these really sensitive issues, it's because of the lack of inclusion. The systemic lack of inclusion all along this pathway is leading us to this point where we're now talking about these issues and under that lens when it's been a systemic problem all along. I'm all about diversity, but boy, you've got to include, and you've got to include people at every single level and listen to what they are saying. We all know what it is to be the token person on a committee. We all know that, and we feel it, and we understand it. I would say if there is inclusiveness and putting that in policy, it's not that I can just look around the table. What are you saying? What are you saying? And listening to what you're saying, that is going to be a part of the solution of what we have to really focus on here.
Yeah, no, I appreciate this discussion. I appreciate the entire panel for joining us. I know we only have a couple minutes, and I want to be able to address maybe a question or so from the chat. I know that there was something that was sent a little bit earlier with regards to healthcare leadership and the sharing of data and information even with staff. Mm-hmm. So you know, really encouraging what we're talking about in terms of the stratification of race, ethnicity, and language data, not only sharing that among leadership, but sharing that, you know, also with staff. And I think it's that level of transparency, and I think my colleagues would agree, that really prompts a different type of conversation. One of the reasons why I've spent so much time focusing on the patient engagement work is because that's a place or a space that everyone knew we had an opportunity. We need to engage the voice of patients more in our quality improvement work. But in that work, I also found a tremendous opportunity, to Dr. Agarwal's point, to really make certain that we were including you know, those voices from vulnerable populations, or the voices that are often not heard. Mm-hmm. And so including those voices has really prompted a different conversation. And I can tell you from, you know, committee to committee, organization to organization, you hear how physicians are saying, you know, when we brought the patient to the readmissions council meeting, it really changed the dynamics of that conversation. And so we definitely want to not just look at making certain that we're hearing the patient's voice, but to what I've heard from all of my colleagues, making certain the assurity that we're hearing from all patients, which is really that inclusion piece. We are at the top of the hour. I don't see another question in here, but I want to thank everyone who's taken the opportunity to participate in today's conversation. We did tape this, so it is fully my intent to not only wrap this up audio, but to also produce a small report that we plan to share with our legislators on the role of hospitals and health systems in eliminating disparities. Again, thank you everyone for joining on today, and be safe.